good morning, good afternoon, and maybe good evening for all the audiences here online. And welcome to today's WFSA World Patient Safety Day webinar. I'm Dr. Shen from Beijing, from Peking Union Medical College Hospital in Beijing, in China. And I am also the Deputy Chair of Safety and Equality Committee of WFSA. And I am honored to be the moderator today here. So today you can see that on World Patient Safety Day, the WFSA's Safety and Quality Pediatric Anesthesia and Obstetrics committees have come together to focus on this vital theme. And we can go back to the theme of today's webinar. And we can see that today, today we will have a webinar on the topic of precision and protection. Advancing anesthesia safety in newborn care to achieve UHC and end preventable deaths of newborns and children under 5. And you know that this is also this year's theme of World Patient Safety Day. And I think after the session, after the webinar today, you may get a lot from all these things. And by the end of this session, we hope you will be able to analyze the risks of neonatal anesthesia, identify the most common complications and their impact, and integrate maternal and neonatal safety considerations into your daily practice. So today we will have 3 talks from 3 famous or well-known speakers on behalf of 3 committees of WFSA. They are Dr. Naeem Yusuf Zakaria on behalf of the Safety and Quality Committee, and also Dr. Vinicius Quintal on behalf of the Pediatric Anesthesia, and also Professor Emilia Guasch on behalf of the Obstetrics. So we will start from the first speakers here. The first speaker is Dr. Naima Yusuf Zakaria, and she, yeah, okay. Oh, one more thing that here you can, all audiences here online, you can raise questions. You can raise questions during the talks, and also, maybe, yeah, during the talks, and after the 3 talks, we will raise questions to the 3 speakers here, and we can have the Q&A session after all 3 speakers' talks. So here, let me introduce our first speaker, Dr. Naima Yusuf Zakaria from Muhimbili National Hospital in Dar es Salaam, Tanzania. And she is our committee member of Safety and Quality Committee of WFSC. And she is also the country representative of SAFE program in Tanzania. And she is also conducting her training for SAFE obstetric course for the past 10 years and simulation training for specialists in her institute, Tanga Regional Referral Hospital. So today, Naima will give us a talk on the topic of the current landscape, understanding the unique challenges of neonatal anesthesia. So please, Naima, you can share your slides and give us a talk, please.
So much, Dr. Lee, for a very good introduction. And I'll be taking you through unique challenges of neonatal anesthesia. And today we'll be talking about anesthesia-related harm, but also physiological factors and the contributing factors which can lead to mortality and morbidity in this special group. But lastly, we'll talk about the devastating complication of anesthesia on them, but also their family members. So, while talking about neonates, we all know that neonates are not small adults. They have immature organ system, which makes anesthesia very challenging. Airway, cardiovascular, and metabolic reserves are limited, so careful monitoring, drug dosing, and perioperative planning are very essential. As you can see, the risk they carry is a lot from a study which was done, showed that airway difficulty was almost to 5.8%, but also morbidity and mortality was almost to the 3.2%. Now, why are they so special? Is because of the risk which they carry. They are very vulnerable because of their age, their young age, they are preterm, and they have very low birth weight, some of them, which makes them to have a high risk um, of adverse effect due to our anesthesia. But also the preoperative comorbidities such as congenital anomalies, infections, and other medical conditions, which make them also vulnerable to be in a high risk group. At the same time, most of the neonates they need urgent or emergency surgeries, which leads to a higher mortality compared to the elective procedures. But also in our setting, for example, in low middle income country, the resource limitations such as lack of the specialized instruments for them, ICU support, monitoring, or trained staff also lead to increased risk in this group. Now, recognizing these factors help us in risk stratification, planning, and counseling families before surgery. So I looked into a study where this study was one was done in Europe, the Nectarian, which consisted of around 31 Europe countries, and it also looked into 165 centers, and it was a prospective study. Almost the study group was around 5,609 infants, and this looked mostly into the neonatal mortality, but also it looked into other factors, and they found out that the critical events which which happened in this patient were almost 35.2% at 30 days complication, and mortality at 90 days were almost I mean, the complication in 90 days was 16.3, but their mortality was 13.9%. The study emphasized the impact of preoperative medical condition and congenital anomalies, whereas the study which was done, I found this study very interesting, which was done by Hamza and et al. In Ethiopia, and this study emphasized on or highlighted the role of preoperative infection comorbidities, but it also kind of identified the gaps which were seen in like late refer, but also prolonged stay in the wards in order to get surgical services, but also it looked into the post-op management, such as lack of ICU or proper place to send these neonates was one of the factors. If you look into the graph, it says that the mortality, overall mortality in low middle income country were almost 14.6%, which was much higher than high income countries. And the most of the death which were contributed in lower middle income country was due to prematurity. And the main cause of death there was delayed care, hypovolemia, sepsis, and most of the surgeries which ended up having high mortality were anorectal malformation and gastroparesis. So the key message here is that although there is a low mortality in high income country, but there was a significant risk after the cardiac arrest. Whereas in low middle income country, the higher overall mortality often was from preventable causes, and that highlighted the need for timely intervention. So looking into the next slide, whereby uh, it looks like the neonates are actually 5 times more higher than pediatrics in getting hypotension, hypoxia, bradycardia, but also airway obstruction, and also they have prolonged drug effect. And it also tells them that because of their physiological reserve, they are at the high rate. Now, looking into their special physiological things into respiratory, neonates have usually high oxygen needs, and a small lung reservoir. So they can desaturate quickly. The airway is also small, easily obstructed due to the large tongue, and hard to intubate due to the anatomical differences, such as the narrow cricoid ring, but at the same time, the larynx being more um, uh, upper. And the compliant chest wall and weak diaphragm makes them prone to easily being fatigued and also atelectasis. Whereas preterm infants, they lack surfactants, worsening hypoxia. So post-operatively, risk of apnea and desaturation is high, especially after the patient's been given sedatives or opioids. So close airway vigilance and careful ventilations are essential. When we look into their cardiovascular system, their myocardium is immature and less contractility, making it sensitive to stress, and they rely on the heart rate to maintain their cardiac output. So bradycardia quickly can cause instability. The blood pressure can also drop easily due to limited ability to increase stroke volume. They are prone to hypertension, poor perfusion, and arrhythmias during anesthesia. Therefore, careful monitoring and gentle blood and drug management are critical. If we look into their brain, into their neural system, the brain is immature and vulnerable to hypoxia, ischemia, and glucose imbalance. They have incomplete myelination, which affects the drug response, making anesthesia effect less predictable. Neonates have a low seizure threshold, increasing the risk of perioperative seizures. They are highly sensitive to sedatives, opioids with prolonged effect, and care must balance adequate anesthesia with neuroprotection to avoid long-term injuries. When we talk about fluid and glucose management, neonates have limited fluid reservoir and high insensitive losses, making them prone to dehydration very easily. They are high risk of hypoglycemia due to limited glucose stores and high metabolic demand. So therefore, careful calculation of maintenance fluid, glucose supplement, and electrolytes is very essential. Close monitoring of the blood glucose and urine output is required throughout their perioperative period. On top of that, they also require specialized instruments like appropriate sized airway equipment, IV cannulas, and monitors. Ventilation or when they are on ventilators, we must allow low tidal volume and precise pressure control. Warming devices are very important in these patients because they get easily hypothermic. Together with all the physiological, even their metabolic, their pharmacokinetic and pharmacodynamic are different in them because they have immature livers and kidney functions, which alters the drug metabolism and clearance. Protein binding is also reduced, so free drug concentration are higher, increasing the sensitivity. Dosing must be weight-based and adjusted for gestational and postnatal age. Anesthesia drug can have prolonged effect, so titration and monitoring are crucial. Now, when talking about the impact of anesthesia complications, these are not only on the neonates but also on the family. The family, they go through emotional trauma, but also financial burden and prolonged hospital stay, which can somehow disturb the stability of the family. Together with that, the neonates themselves, they have a high risk of ending up either with a disability or mobility or mortality, and that can now lead to social constraints such as healthcare resources are now they become limited, but there is a increased demand of this neonatal care, which is very expensive, and it requires a lot of budget set aside for that. Um, so when we talk about ways of how do one can mitigate these challenges is by enhancing perioperative monitoring, but also having temperature management properly kept properly, like in the theaters, but also in ICUs or post NICUs. Dose precising is very important. I always talk to my juniors that whenever we need to give medication to neonates, we need to dilute them and use smaller syringes instead of having a large like 10 cc get it into the patients, because we need to be very careful about the fluid but also dosing of our medication. Multidisciplinary team approach is very important when it comes to neonate. Us as anesthesiologists alone, we might sometimes get challenges, especially when it comes to the dosing. So it's important to have the pediatricians, the nutritionists, the surgeons all together working as a team in order to give appropriate care to this patient. But to have a standardized perioperative guideline, I'm so glad that in Tanzania now we have at least three pediatric anesthesiologists who can then help us to look into more detail about the care we give to this patient, and enhance training and simulation in order to reduce the medical errors. So all in all, um, as anesthesiologists, we have a crucial role in playing when it comes to neonatal anesthesia, because we need to look into the pain relief, maintaining oxygen, ventilation, circulation, and temperature regulation, but also in precise dosing for this drug dosing in this patient. And on top of that, our vigilant care is very important. But for further improving the care in neonatal, we need to have a research initiative, advanced training programs in order to enhance the neonatal anesthesia safety, but also efficacy. My key message to all of you who are listening is neonates are unique due to their anatomical and physiological development, and neonatal anesthesia demands for specialized expert vigilant monitoring and timely intervention so as to improve the quality of service we give to this our babies, and also it helps to reduce morbidity and mortality. Thank you very much for listening.
Okay. Thank you so much for Dr. For Naima, for Dr. Zakaria, and I think that's a very insightful talk for all the audiences here online. And I thank you so much you shared here with some very famous references or literatures that give us a fact that there is a really big gap between the high income countries and also with the low and middle income countries. And I think you also give us some very necessary or important information that we should care about neonatals' respiratory, cardiovascular, and also nervous system. And especially for the anesthesia for the neonatals, we should have some special considerations for the fluids, also the medication, also about the equipments. And the last but not the least, you said that I absolutely agree with your opinion that we anesthetists or anesthesiologists, we really play very important roles in the neonatal safety. Thank you so much, Naima, and I think maybe we other audiences will have some questions later after the other two talks. So thank you, Naima, again. And now let's move to our second speaker, Dr. Vinicius Quintal from the Federal University of Minas Gerais, Brazil. And yeah, Dr. Vinicius Quintal, he is how to say he currently serves as co-responsible from the medical residence in anesthesiology at the Medical University São Paulo. And today, Dr. Vinicius Quintal will give us a talk about the topic of the strategies for strengthening anesthesia safety in newborns. And so let's welcome Dr. Vinicius Quintal's talk, please.
Thank you so much, Dr. Shen, for the kind introduction and also for the kind invitation. Can you hear me?
Yes, perfect, yeah.
Okay, great. So let's share my presentation. So as I was introduced, I'm Vinicius. I'm a pediatric anesthesiologist. Actually, I'm from University of Minas Gerais, which was my home state here in Brazil. But now I live in São Paulo, where I serve as a pediatric anesthesiologist at University of São Paulo. So my objective here is stated here in this slide. So first, we will identify the key anatomical and physiological differences in neonates that are particularly important for airway management and respiratory physiology. So I'll focus on airway management. So with only 15 minutes, I decided to discuss a very important and scalable strategy to mitigate the complications. Second, I will explain how these differences affect clinical practice, especially when it comes to intubation and perioperative safety. And third, we review the available evidence for low flow apneic oxygenation as a simple and scalable intervention to increase safety in neonates who need surgery. And finally, discuss how to apply these strategies in practice, focusing on how to set up, what flow rates to use, and how to monitor patients effectively. So we are just discussing our learning objectives, and our learning objectives focus on understanding the unique challenges of neonatal physiology and identify simple, scalable strategies to keep these patients safe during anesthesia. And this connects directly with the broader global movement. So today is the World Patient Safety Day, and the goals for 2025 is the safe care for every newborn and every child. So this must be a priority. And this isn't just about improving outcomes in our hospitals. It's about aligning with an international agenda that recognizes newborns and small children, small infants, as some of the most vulnerable patients, as Dr. Zakaria just gave us her introduction in her lecture. So when we talk about applying evidence-based strategies like low flow apneic oxygenation, we are not only improving safety at bedside, we are also contributing to these global goals of equity, safety, and universal access to quality care. As part of the World Patient Safety Day 2025 agenda, 5 global goals have been defined, as this slide states. And the most relevant discussion here is the goal 5, so reduce risks for small and sick newborns. And this reinforces that neonatal safety is not just a local and individual concern, it's a global priority. So our efforts improve airway management in promoting safe intubation practice in newborns directly contribute to this 5th goal of this agenda for the World Patient Safety Day. So we just seen that one of the goals for patient safety is to reduce risk for small and sick newborns. And this is not by chance, because the evidence show us how vulnerable this population really is. So Dr. Zakaria showed us the nectarine study, but here I'll show you the apricot study. which is the largest prospective trial in pediatric anesthesia with more than 13,000 children across Europe, demonstrated very clearly that the youngest patients, especially neonates and preterm infants, face the highest risk of severe or critical events. So prematurity increase the incidence of respiratory adverse events. And we see here in this graph that the first months of life, actually the first years of life, complications are predominantly respiratory, desaturation, laryngospasm, difficulties with airway management. And this extremely relevant because respiratory complications in neonates, particularly infants, can very quickly become life-threatening. So their physiology leaves little margin for error. And even short episodes of hypoxemia can escalate to bradycardia or even cardiac arrest. So while APRICOL reflects data from well-resourced European centers, it highlights just how fragile this population is. And in our settings, Brazil is a low and middle income country when resources may be more limited. The risks are likely even greater. So that's why focusing on airway safety and prevention of respiratory complications must be a absolute priority. So before we go to the airway challenges, let's start with the basics and review some of the definitions about gestational age and birth weight. So a preterm newborn is any baby that born before 37 weeks of gestation. Within this group, we can classify them according to their birth weight. So low birth weight, less than 2.5 kilos, very low birth weight, less than 1.5 kilos, and extremely low birth weight, less than 1 kilo. And sometimes we even use the term micropremise for infants weighing under than 650 grams. So in contrasting term, newborn is born between 37 and 42 weeks, and post-term newborn is any baby delivery after 42 weeks. And these definitions are not just academic, they matter because they directly influence how we manage these patients in the operating room. So the more premature and the smaller the baby, the higher the risk of complications. So that's why in the next slides, we'll look at the anatomic and physiological differences that make neonatal airway management so challenging. Okay, so now that we have reviewed definitions of preterm, term, and post-term newborns, let's look at how to translate into clinical examination. This is very important. One structured way to assess maturity is the WFSA score. WFSA score is a very relative old score, but we can apply nowadays. Even today, we can use nowadays we can use this classification, which evaluates several parameters, including muscle tone, for instance. So preterms infants are usually hypotonic with weak and easily fatigable flexion of the limbs and strong coordinate reflexes. So these simple bedside observations not only help us estimate gestational age, especially in those when we have a doubt about the gestational age, but also anticipate the risks we'll face in anesthesia, particularly when we move on to discuss the anatomical and physiological differences in the neonatal airway. So after reviewing the general features that help us distinguish preterm from term infants, let's now focus especially on the airway. So one of the first things we notice is that the tongue is proportionally larger in newborns compared to the size of the oral cavity, the oral cavity. At first glance, this might suggest that the tongue is the main cause of airway obstruction, but in practice, that's not the case. In infants, airway obstruction is more often related to the collapse of the nasopharynx and the epiglottis, especially under anesthesia on sedation when the muscle tone is reduced. And another key difference is the position of the larynx. So the larynx sits higher in the neck, usually around C3, C4, whereas in adults, it's lower at C5, C6. And this higher position of the larynx makes the angle for the visualization different during laryngoscopy. And we look at the epiglottis. It's often longer, narrower, and more floppy in infants. In many cases, it even has these characteristics of a omega, the letter omega shape. All these anatomical differences contribute to the greater difficulty we face in visualizing the glottis and performing intubation safely in this population. So building on what we just saw about the unique anatomical features of the neonatal airway, so this figure is very important and help us to understand why airway obstruction is so much critical in infants compared to adults. So on the left, we see that the airway diameter, so about 44 millimeters in infants and 8 millimeters in adults. And now, if we just add 1 millimeter of a circumferential edema, the reduction of the cross-sectional area is dramatic, around 75% in infants compared to only 44% in adults. And according to the Poiseuille law, resistance in laminar flow increases inversely with the radius of the fourth power to the laminar floor, and in the turbulent floor to the fifth power. What does it mean? In practice, it's very important because in infants, only 1 millimeter of edema can increase resistance 16-fold in laminar flow and 32-fold in turbulent flow, compared to the adults only 3-5-fold. So this illustrates why even minor changes in airway diameter, whether from edema, secretions, or airway manipulation, can quickly lead to severe respiratory compromise in newborns. And it reinforces why airway management in neonates and preterm infants be carried out with extreme care and also anticipation. So it's also very important to remember birth. The entire cardiopulmonary system goes through a dramatic transition. So this slide illustrates the main events in the shift for fetal to neonatal life. So while with the very first breath of a newborn, it generates a very high transpulmonary pressure between 40 to 80 centimeters of water. So once this effort, this first inspiration is essential to expand the lungs for the first time and also to clear the fluid that fills the alveoli. And once the lungs are aerated, the pulmonary vessels open, leading to the rapid drop in pulmonary vascular resistance. At the same time, the interruption of placental circulation causes a rise in the systemic vascular resistance because the low resistance umbilical circulation is gone. So these hemodynamic changes drive the functional closure of the foramen ovale and the ductus arteriosus, which completes the transition from fetal to neonatal circulation. And for us, pediatric anesthesiologists, this physiology is key. So any factor that delays lung aeration, increase pulmonary vascular resistance, or interferes with the shunt closure can destabilize the neonate very quickly in the perioperative settings. Now look at the respiratory muscles. We can add another layer of complexity. Infants, especially those under 1 year of age, are highly dependent of diaphragm for breathing. So their intercostal muscles are not yet fully effective, and because the costal arcs are not completely ossified, the chest wall lacks stability. Another important point is that infants have a low proportion of type 1 muscle fibers, that fatigue resistance fibers. So this means that their respiratory muscles tire easily under stress, such as during illness, anesthesia, and prolonged intubation attacks. And there's also a problem of compliance. So infants have low lung compliance, which makes expanding the lungs more difficult, while at the same time, the chest wall is very compliant, tending to collapse inward during inspiration. So this imbalance results in less effective ventilation. And when we put all these factors together, the immaturity of the diaphragm, the highly compliant chest wall, and the limited endurance of respiratory muscles, it becomes clear that neonates are particularly prone to respiratory fatigue and failure. And building on what we have seen regarding respiratory muscles in their vulnerability, here we shift to the lung volumes, which also play a critical role in physiology of newborns. On the left, we see the infant's lung capacity. So we have the tidal volume compared to the adults, but the most striking difference is the relationship between closing capacity and functional residual capacity. In infancies, the closing capacity often exceeds the functional residual capacity. This means that even during normal, quiet breathing, small airways are closing at end expiration. The result is a much greater tendency for atelectasis, hypoxemia, and ventilation perfusion mismatch, particularly under anesthesia when muscle tones and spontaneous efforts are reduced. So this explains why infants desaturate much faster during apnea, obstruction, and even brief interruptions in ventilation. And lastly, the control of breathing. So the neonates, in neonates, the respiratory is quite different. The regulation of the respiration is quite different from adults. One important point is that hypoxia does not potentiate the ventilatory response to hypercapnia. In fact, hypoxia can actually suppress the response to high CO2. And during the first week of life, the ventilatory response to hypoxemia is still immaturate, which explains why neonates often present with periodic breathing partners. While periodic breathing partners may be benign, we also see apnea of prematurity, especially in infants younger than 60 weeks post-conceptional age. Another important difference is the baseline oxygenation. In neonates, the PO2, the normal PO2 is lower between 16 and 19. And finally, the oxygen transport, which is influenced by the hemoglobin type. So neonates have fetal hemoglobin, and fetal hemoglobin has a much higher affinity for oxygen than adult hemoglobin. For instance, the P50 of the fetal hemoglobin is 19 compared to the adult hemoglobin, which is 17. So this tighter binding is advantageous, of course, for the placental transfer, but it also means that the fetal hemoglobin delivers less oxygen to tissues, which can contribute to hypoxemia during stress. So when we combine these factors, the immature control of breathing, the low oxygen baseline, the high levels of the fetal hemoglobin, we understand why neonates, especially preterm infants, are at a great risk for hypoxemia and apnea during anesthesia. So after reviewing these anatomical and physiological characteristics of neonates, it becomes clear that airway management is especially challenging in this group. So tracheal intubation neonates is technically more difficult due to the anatomical features that we discussed. And our goal during the intubation is to achieve first attempt success without adverse events such as bradycardia and hypoxemia. And we can see in the last publication of the PED registry that every additional attempt at intubation is associated with the marked increase in the risk of complication. So given the right risk of complications with repeated intubation attempts in neonate, we must look for strategies that can make this process safer. And one simple and effective technique is to use the low flow apneic oxygenation during intubation. The idea is to maintain oxygen delivery even when the infant is apneic, buying us extra time to reduce the risk of desaturation. And this is endorsed by many algorithms. So the last ASA guidelines, which has a specific guidelines for pediatric anesthesia, we put here to optimize oxygen throughout the attempts using apneic oxygenation. Also, the recent Brazilian guidelines in airway management in children also recommends apneic oxygenation. And in the most recent neonatal airway guidelines. So the authors explicitly recommended the routine use of apneic oxygenation during intubation. Even though the recommendation, the level of evidence is 1B, but they recommend it. And one of the landmark studies in this field is this first randomized trial. It was the first one to show that a very simple intervention, apneic oxygenation with 5 liters per minute, could significantly extend the safe time during pediatric intubation. When it comes to newborns, we don't have a single gold standard recommendation. However, in clinical practice, several flow ranges are feasible and safe. So we can only use 5 liters per minute or 0.2 to 1 liter per kilo per minute up to 10 liters per minute. So we don't have now the best way to do apneic oxygenation, but we know that we must provide apneic oxygenation. And to conclude, and finally, I would like to close this presentation with this ongoing international study, which is in the recruitment phase. This trial, we are comparing apneic oxygenation without apneic oxygenation, using a flow of 1 liter per kilo per minute, up to 10 liters per minute. In neonates, up to 52 weeks post-conceptual age. Our center here, Brazil, is coordinating this study. So to conclude, we have seen that newborns, especially preterms, are uniquely vulnerable because of their anatomical and physiological characteristics. This makes intubation particularly challenging with the high risk of adverse events. Apneic oxygenation, however, stands out as a simple, scalable, and effective strategy that is already supported by international guidelines, and soon we may have stronger evidence to firmly establish as a standard practice for intubation in neonates. So I'd like to sincere thank you all for the attention and thank you for the invitation. This is our hospital here in São Paulo. Thank you very much.
Thank you so much, Vinicius. A very beautiful hospital, and I think it's a very important topic for the apneic oxygenation. We know that it's very useful for the adults, difficult airway management, and especially for the preterm babies. That means they have premature airway, and that means they have difficult airway. So maybe the apneic oxygenation give them a new way or a much better way than before to manage all these difficult airways for the preterm newborns. And I hope that you can get the perfect results after the trial, and maybe more centers will enter your trial after the talk. So thanks again. And then let's come to the third speakers here. Also our last speaker, Dr. Dr. Emilia Guasch. And yeah, we know that Emilia Guasch on behalf of the obstetric committee here, and so Dr. Emilia Guasch is an obstetric anesthesiologist. She is also currently work at uh, the University Hospital of Madrid. Yeah, from Spain, Madrid. And Dr. Guasch is current member of ISAC board, and also she represents the obstetric committee today. And Dr. Guasch will give us talk on topic of safe obstetric anesthesia and analgesia for safer neonatal outcomes. So please welcome.
Hello, everyone. My hospital name is Hospital Fundación Jiménez Díaz.
Hello, everyone.
I'm WFSA committee chair. The presentation is pre-recorded, so listen to the presentation, please.
Hello, everyone. Thank you very much for inviting me to speak about safe obstetric anesthesia and analgesia for a safer neonatal outcome. I'm Emilia Guasch, the current chair of the obstetric committee of WFSA. So, the goals that we are going to try to achieve here in this lecture is to speak about maternal mortality and some inequities, some few words about anesthesia and maternal safety and neonatal safety also, and additional risks in low-resource settings related to anesthesia. We will try to conclude with some practical points to improve maternal and neonatal safety. Let me try to start with two maps and to see how parallel and how similar they look. The World Anesthesiology Workforce Map and the maternal mortality rate in 2020. The lower the number of anesthesiologists in the world, the higher the maternal mortality. So it is a matter of concern, and it highlights the important role of anesthesiologists in decreasing maternal and neonatal mortality. The trends in maternal mortality in India in several decades have been going down, but it's important to highlight that the main cause of maternal mortality is hemorrhage. There are 4 causes of maternal mortality that are preventable in low resource setting and in low and middle income countries. They are hemorrhage, sepsis, hypertension, and unsafe abortion. If we take a look to the maternal mortality in the UK and in Europe in general, we can see that the causes are completely different. But if we analyze by mortality causes the ethnic groups, we still can see that Black women and Asian women die more often than white women, And if we see about deprived areas, most deprived women die more often than less deprived. So the question of low-income countries is also transferred to high-income countries. Maternal mortality and morbidity are related to anesthesia in low and middle-income countries, especially in low-income countries. Maternal mortality related to general anesthesia is 5 times higher compared to regional anesthesia, and mainly due to airway problems, aspiration, hypoxia, and lack of monitoring, and also lack of critical care backup. Spinal anesthesia is initially safer, but it's not safe 100%. It is also risky, mainly due to a high incidence of hypertension and how difficult it may be to treat or even to prevent hypertension in low resource setting. Lack of vasopressors, the absence of choices and the need to choose not the right one, and the absence of pumps. The lack of fluids may be also a contributing factor, or not the right amount of fluids, and dehydrated patients when they arrive for a cesarean delivery, and lack of monitoring. That difficulties the resuscitation needed in those cases. There are several key neonatal outcomes: perinatal mortality, severe perinatal mortality, that means need for advanced resuscitation, neonatal intensive care admission, and others. And also immediate depression at birth with low UPCAR scores and neonatal acidemia, and respiratory morbidity as a consequence of all this. Most of these severe adverse neonatal outcomes are more associated to general anesthesia and to emergencies. Let's try to analyze the technique of choice, paying attention mainly to neonatal impact. Neorectal has better outcomes, even in low and middle income countries, but if we take a look to the Cochrane meta-analysis and systematic review, there is no clear evidence at the moment, but it is a different environment. General anesthesia has, as we have mentioned before, 5 times more mortality in low and middle income countries because of lack of trained staff, because it is more used in emergencies, and it's even more used in sick mothers. And what about neonatal outcomes? With regional anesthesia, we can find, after this wide analysis, because of who survey very, very wide with a lot of patients, a lower odds of neonatal near miss, severe neonatal outcomes, UPGAR score less than 7 at 5 minutes, and less number of neonatal intensive care unit admissions. Regional anesthesia is also associated to a lower odds of early neonatal death, even ante or intrapartum, when even ante or intrapartum cesarean delivery is needed. But we have mentioned a couple of times until this moment the emergency situations that are related to worse outcomes. So we should speak about this with the same language and to have a uniform classification for emergency cesarean deliveries. And then we have the Lucas classification, that we have a grade from 1 to 4. Category 1, emergency C-section, is that one that it's indicated because of immediate threat to life of woman or fetus. We have to deliver the fetus as soon as possible. And category 2, cesarean delivery, is also an urgent situation, but it's not related with an immediate life-threatening, but it can go to an immediate life-threatening. A scheduled C-section is that one that is needing an early delivery, cesarean delivery, but not because of maternal or fetal immediate compromise. And elective is when all the stakeholders choose the right time to perform a cesarean delivery. So regional anesthesia and analgesia, because it's not everything anesthesia, and the possibility to have spinal or epidural is a question of three simple things: money, education, and healthcare system organization. Epidural analgesia means that we have at least trained anesthesia provider and increases the safety in the labor ward because anesthesiologists are around and may perform basic and advanced measures for patient's resuscitation. Spinal analgesia, in terms only of analgesia for labor pain, is better than nothing, but not enough. It can be performed, but not trained anesthesiologists, not training anesthesia providers, and it has a limited duration and not enough for for a cesarean delivery because of this cause, because of limited duration. There are some barriers for labor analgesia all over the world, especially in low middle-income countries: economical, cultural, religious, but mainly related to financial issues with healthcare systems. The solutions are mainly education and campaigns related to convince our authorities and politicians that they have to invest in labor pain. From WFSA, we have made important efforts with the recent Declaration on Patients' Rights to Labor Analgesia that has been launched last June 2025, and also with the Safe Anesthesia from Education. The SAFE programs, that means safer anesthesia from education, have been developed for more than 10 years, up to 15 years, in low and middle-income countries, and are especially dedicated to the pediatric and the obstetric field. And they train anesthesia and non-anesthesia providers to give a better and safer attention. We have system and contextual drivers of maternal safety. One of the most important is human resources. Many cesarean deliveries are conducted by non-physician anesthesia providers with lack of training. And this is all what we may have in some areas because of workforce crisis. We have a recent survey and a recent publication from WFSA about workforce crisis. And let's remember the first map we showed. The less the number of anesthesiologists, the higher the maternal mortality. The infrastructure gaps, lack of reliable oxygen supplies, even suction or monitoring, no postoperative care unit or even intensive care unit, and all of this increases anesthesia-related mortality. Emergency preparedness is also important in some parts. In some areas, the absence of protocols for emergencies related to anesthesia for situations as important as failed epidural, failed intubation, and massive hemorrhage. And contextual drivers are also important for neonatal outcomes. Training and supervision are important in anesthesia, but also are important for neonatal care, especially in a depressed neonate. Lack of basic monitoring, even pulse oximetry should be available in 100% of patients and environments. The delay between the decision to perform a cesarean delivery and incision, it is closely related to bad neonatal outcomes, and the lack of neonatal resuscitation equipment, not only human resources, also equipment. These factors may be even more important than anesthesia technique. But if we have to put the patient to sleep or to put the patient under regional anesthesia, we have to choose drugs. And for general anesthesia, we have ketamine-based techniques that are quite popular in low and middle-income countries. They are mainly used by non-physician anesthesia providers, and they may increase safety, but it depends also in training. They may decrease safety. If no supervision and available, ketamine-based techniques may be the only one option. The induction and other IV drugs must be used judiciously, avoiding the use of opioids and benzos before the cord clamp, because we have to consider the placental transfer, and oxygen administration sometimes is lacking or scarce or unsafe. We have to consider that oxygen has to be needed for general anesthesia, but not needed for routine regional anesthesia for cesarean delivery. The airway and respiratory risks are a real challenge when we have to perform a general anesthesia, especially in low resource setting, as it is the leading cause of maternal mortality related to general anesthesia. It happens more often in these environments because of limited equipment, including suction, working laryngoscopes. There may be laryngoscopes, but without any battery, oxygen, and human resources, lack of training to perform a safe and smooth intubation, and lack of workforce. The availability of capnography or even pulse oximeters to check a correct intubation is also a contributing factor of respiratory risks and airway crisis. The cardiovascular risks are important also in these settings. Severe maternal hypertension, mainly related to regional anesthesia, may lead to maternal and fetal collapse because of uteroplacental perfusion, as you may know, and the death risks is twice as in other environments. Lack of vasopressors, the right vasopressor, or even ephedrine or phenylephrine that should be indicated, worsens the results. In some places, only adrenaline is available, and there are additional risks if we use boluses. There are risks in perfusions because of dilution mistakes or mistakes in the programmation, in the programs or the function of the pumps, and risks also of no monitoring to see the response to these drugs. There are also risks for something that happens very often after a delivery, that it's a postpartum hemorrhage, and the additional risk of prepartum anemia. Maternal outcomes are even worse when PPH is associated to anesthesia because more complications may appear. Anemia is more prevalent prepartum in low and middle-income countries and worsened outcomes. So we need to have anemia awareness and to apply as soon as possible and as much as possible the PBM principles in every pillar, the three pillars: prepartum, intrapartum, and postpartum, and paying attention to anemia, postpartum hemorrhage, and postpartum tolerance to anemia. Anesthesia, general and regional, induced hypotension that may be even worse with PPH and may even mask regional anesthesia, especially the PPH consequences and the evaluation of severity of the patients. Drug safety needs an additional attention. Ketamine and ketamine-based regimes, we have mentioned up to this moment that they are widely used mainly by not-physician anesthesia providers, for cesarean delivery and also for emergency cesarean deliveries. It is relatively safe for the mother because it preserves airway reflexes, maintains blood pressure, and avoids the need for intubation that, in absence of anesthesiologists, let's repeat that it's the main source of problems and maternal mortality related to regional anesthesia. The risks of ketamine use are hypertension, tachycardia, and agitation. Halothane, available in some places, is still used in some low-resource settings, and the main risks associated to them are arrhythmias and uterine atony. Arrhythmias may happen even more often in the context of BPH, and uterine atony may lead things even worse. Which is the role of WFSA in this context? The development of the SAFE program with the SAFE Obstetrics and SAFE Pediatrics has been proved as a useful program, saving lives and educating anesthesia providers to provide a safer anesthesia. From our Obstetric Anesthesia Committee, focusing on low middle-income countries improvement, we have collaboration with other committees to improve maternal safety and not only work in maternal mortality, also work in patients' dignity and labor analgesia programs. The mentoring program inside of WFSA goes deeper in training and education for younger generations that are the future of our specialty and of our world. The fellowship programs with a specific program training in obstetric anesthesia is also one of the strengths of WFSA programs, and the World Congress of Anesthesia, with grants for low middle-income countries attendance and providing motivation, research, and opportunities for network, are also a good opportunity for them. The principles to increase safety, neonatal safety in these settings, let's try to summarize them. If it's possible, let's choose regional anesthesia and have protocols for rapid sequence spinal anesthesia in case of an emergency cesarean delivery. If general anesthesia has to be performed because of contraindication of regional or category 1 C-section, use standard protocols. Avoid delays to try to get a safe mother and a safe neonate. Avoid opioids and benzos as much as possible until cord clamp, and optimize the neonatal transition with back mask devices available and with delayed cord clamp and early skin to skin. Train, audit, and simulate with regular drills for routine and critical situations. Be ready to act for maternal safety in low resource settings. Avoid additional complications. Be ensured that protocols for failed spinal and high blocks and other emergency situations are available and known by everyone. Monitor basics, universal pulse oximetry, ideally also capnography, blood pressure, and early recognition of hypertension is essential to avoid complications related to regional anesthesia. Rescue preparedness with airway algorithm checklist, bag mask, and supraglottic devices. And be sure that we have drugs and fluids. Ensure vasopressors, ideally the right vasopressors, IV fluids, oxytocin, and tranexamic acid to avoid PPH appearance and to avoid that things go even worse. The take-home messages from my point of view add that in low-resource settings, maternal anesthesia-related mortality is much higher than in high-income countries, and the causes are also different. General anesthesia has a higher risk of maternal mortality. Spinal anesthesia is initially safest when well-trained attendant is in charge, so let's train people and providers. Ketamine-based approaches may save lives in every poor scenario. Lack of resources and training, system strengthening, oxygen, monitoring, training improves survival as much as anesthetic drugs. Let's try to involve other stakeholders for safety in our operating theaters and in our countries. So a late reminder that we need you to make the magic happen in the next World Congress of Anesthesia. Thank you very much, and I'm open to your question or comments.
Okay, thank you, Dr. Guash. Thank you, Amelia, for your fantastic talk, and especially for the several important messages you transferred to all the audiences here online. And I absolutely agree with you that spinal anesthesia may be the safest way for the obstetric anesthesia, and I really remember the four important principles for the safe obstetric anesthesia, and I really agree that the safe and obstetric anesthesia must can bring much safer neonatal outcomes. So thanks again, and one more that I want to show my heartfelt thanks for you that you answered all your questions in the chat during your talk, and I think that it's a such a good way that we can next time maybe we all can use the recorded video, and we can also answer the questions during the talk and the whole procedure, and I think the time is so limited that we have three very fantastic talks tonight in Beijing, maybe the morning, maybe the afternoon for you in your countries. And here, just as the moderator here online for these webinars, I think I can raise one question that may be useful for the audiences here online, and maybe can be answered by all the three speakers here online. That we know that this year's theme is about the safety of newborns and children's. So in many parts of the world, you know that pediatric anesthesia subspecialty training is not mandatory. For example, in China, the pediatric training is not mandatory for all the anesthesiologists, it's not for all the hospitals, and not for all the regions. And so, can I invite each of you to give us some experience or your own condition about the current situation in your country, and how do you train the pediatric anesthesia fellowships, and are there any mandatory rules or policies in your country that the anesthetist and anesthesiologist need to get certified after several years of fellowship training in the pediatric anesthesia, and then give the anesthesia practice to the neonatal. So I think maybe first, please, Dr. Naima.
Thank you very much, Dr. Lee, for the insightful question. We do not have official training in Tanzania for pediatric anesthesiologists, but through WFSA fellowship, we do go to Kenya, which is just nearby, and do our fellowship. And so far, we have three pediatric anesthesiologists and three are studying. So altogether, 6 out of 90 anesthesiologists who are now in Tanzania. So yes, you are very true. Even when before I came to my center as an anesthesiologist, we used to refer all the neonates surgery to be done in a specialized hospital. But as being anesthesiologist, and working with this neonate, because we have been taught in our program, so it was easier, and it's now all the neonatal surgery we do them here. The problem comes after care. Post care is a very much problem, because the neonates are not handled by the neonates nurses who are trained, and the pediatricians are just pediatricians. They are not neonatalists. So that brings like a kind of like a problem yet. But yes, it is. They are recognized when it comes to recognition. They are recognized as a super specialist. There is a motivation driven by our society for people to go and take more pediatric anesthesia. But as a national policy, no, we don't have that yet. But they are very important to have them. We agree. Thank you. I hope I've
Oh,
answered
yeah,
the
yeah.
question.
Okay, thank you, Naima. And how about the condition in Brazil, Dr. Vinicius?
So thank you so much for the question, Dr. Shen. Also, the same in Brazil, we don't have a mandatory training for pediatric anesthesia, unfortunately. So it's a huge country with a huge territory, and as far as I know, only 5 centers has a fellowship program or a additional year in the residency dedicated to pediatric anesthesia. So here in São Paulo, we have a fellowship program, but it is supported by the university. So it's a extension activity of the university. So we do the residency in anesthesia, and then you apply for a year for fellowship, a year or two for the fellowship. So we are in the beginning. It is the next year will be the year number 5 that we have this fellowship program, but still we don't have this regulation by the National Society about the pediatric anesthesia, and I think we won't have this very soon because as many parts of the world we lack anesthesia in Brazil, and if when we finish your residency program, you go straight to the market, so you don't have time to do an additional training, unfortunately. But still, in the main centers like São Paulo, we have this support from the university, and we are doing this training very, at least from my perspective, very successful until now. So let's hope for the future, especially for newborns, which I believe to be a specialist is very, very important.
Okay, thank you. Thank you for sharing your current status in Brazil, and maybe we have the same condition in China, and we also look forward to the coming future. It will become better. And the last but not least, Dr. Amelia Guash, and I think you can share with us more experience, not only the pediatric anesthesia, but also the obstetric anesthesia. And we know that both anesthesia subspecialties are very important, and maybe the fellowship training for the both subspecialty anesthesia also very important. I'd like to know something more from you, Dr. Amelia.
Well, thank you. Thank you for the question. But we don't have an official fellowship program in Spain, neither in pediatric nor in obstetric anesthesia. But for pediatric anesthesia, we have one paper from our national society that says that children under 2 years old should need to be anesthetized in a special children's hospital. This is what the paper says. But in the practical sense, only neonates and high-risk neonates are sent to special children's hospitals. In most of hospitals, the anesthetists with a special dedication to pediatrics, but without any official training. In obstetric anesthesia, everyone is entitled to do obstetric anesthesia. And in my experience, if you want to see one anesthesiologist trembling, send him or her to the delivery suite. he will tremble or even have seizures.
Okay. Okay, so I think it's 9:20. It's 9:20 now PM in Beijing, and maybe we need to conclude to the end of this webinar, and thank you all three speakers for your contribution and for your fantastic talks tonight and today, not tonight, today. And thank you so much for all the global audiences for you to join us on this World
So,
Patient Safety Days and webinar.
Dr.
And
Lee, sorry, Dr. Lee, there is a very question popping up in the chats about the certificates. Can you clarify that? They are
Oh,
asking, many attendants are asking for the certificates, and if they'll be given, or what is the procedure? Yeah.
okay, Rosa.
Yes, so as you can see in the screen, everyone will receive a certificate of attendance if you attended for at least 60 minutes.
Okay, thank you. That's very important. Yeah. So, last, and on behalf of WFSA, we look forward to continue this important conversation and also this topic in the future about newborn anesthesia safety. So, let's conclude today's webinar. Is that okay, Rosa?
Yes, thank you all.
Okay, thank you, Rosa, for your arrangements, and thank you, Dr. Naima, thank you, Dr. Amelia, and thank you, Dr. Vinicius. Please forgive me about the mispronunciation of all your names
No
and
problem.
the name of your institution. And we are looking forward to meet you on site in the coming WC in Marrakesh, Morocco. So, yeah,
Sure.
thanks again. Yeah.
Thank you so
Yes.
much.
Thank you.
Yes.
Thank you so much.
Thank you so much. Yeah.
Bye.